So any of the anaphylactic reactions to stinging insects can include itching and burning, wheals,
Cool Whip,
and then some swelling around the initial offending wheal or the injection site. If they are complaining of chest tightness and coughing because of that mucus production and the bronchoconstriction or bronchospasming, and then the abdominal cramps. Any of these can progress extremely rapidly to a point where more often than not the patient's going to go into some kind of respiratory failure, then respiratory arrest, and then obviously cardiac arrest from that point. Some of the more common things that cause some kind of anaphylaxis is insect stings, and this is honeybees, wasps, and things of that nature. Honeybees actually can only sting once. They are sacrificial. They have a small barb on the end of the stinger, and when they actually inject into the skin, the stinger is stuck, and as the bee pulls its thorax away, it will pull some of its internal organs out, and quite often there is a small muscular pump on the stinger which has the venom sac, and this will actually continue to keep pumping venom into the skin long after the bee has removed itself. Wasps and hornets lack this barb. They will sting repeatedly and multiple times, injecting venom into each actual penetration. In regards to an ant, the ant is a little bit different culprit than, say, a bee or a wasp. An ant will actually bite using its mandible to clamp down onto the actual victim, and then if it's so equipped with a stinger, it will actually use the stinger out of its thorax and inject venom multiple times across that. And so this is really commonly seen in what we would call like a fire ant, where you can get tens if not hundreds of these things clamped down onto some skin, and they're all stinging, which is going to create that kind of severe reaction in a localized area, or in the case of anaphylaxis, the body will over-respond, and then the entire body responds to that venom. So as we're looking at this picture here, you can see an insect sting, and if you're looking closely at the picture, you can see a kind of off-shaped, right? It's not quite round or perfectly circular. This is what we call a wheal.
Cool Whip.
The wheal is the localized inflammatory response to the actual site of injection. Due to the way that the venom is designed, the body will immediately have a sensation of pain, and then that localized swelling. There will be some localized heat because of the inflammatory response. So the skin now has let the histamine response begin, which is causing that vasodilation in the specific area, and the blood flow is now increased to that, and then the leaking of the interstitial fluid. All of this creates a very localized hotspot, if you will, right to the site of injection. This really doesn't require any treatment. While it may be uncomfortable, the body will do what it's supposed to do and kind of return back to normal, and the pain will subside. So we're dealing with some kind of allergic reaction or anaphylaxis. Primary assessment is probably your best friend here. We really want to make that determination of sick or not sick. And as we discussed in class, your primary assessment should almost always start off with the across the room approach, where we're looking at what is their level of consciousness, and do they have a normal respiratory drive, or are they in some kind of respiratory distress or respiratory failure. As we approach them, if they are conscious and alert, or even conscious and they have some kind of respiratory drive, we know by default that they have to have some kind of circulatory drive, which means that they still have a pulse and some kind of blood pressure. So the big tips here are as you walk in, you want to make this assessment and look at mentation being the key driver to your sick or not sick. As we make contact with the patient, at that point we want to know what their mentation actually is. Are they alert and oriented? What does their skin look like? Do they have a good strong radial pulse, and are they breathing without any kind of wheezing or other respiratory issues? And then we can kind of start to determine, is this a mild to a severe allergic reaction, and are we going towards full-blown anaphylaxis? Allergic reactions can really pretty much show up as shock, right? And that's should be kind of a no-brainer for you guys, because in all reality, if we have a pretty systemic allergic reaction to something, we are going into shock just by the definition of shock, which is hypoperfusion of the tissue. And so if you have decreased blood flow because of leaking pipes and the decreased ability to have cardiac contractility, as well as the inability to actually move and have a gas exchange in the lungs, we are hypoperfusing any and all tissue that's associated with that. And so a lot of patients who experience this will go have allergy tests done, and then they will know that they have a very specific allergy to X offending agent. Those patients will sometimes wear a medical ID bracelet or a tag, and if they know that they have a significant likelihood of going into an anaphylactic shock, a lot of these patients will carry EpiPens on their person. Back into that primary assessment, airway and breathing, right? So we walk in the door, are they breathing? Are they breathing normally? What is the rate, depth, and effort? And can we hear any audible stridor from across the room? If we hear it from across the room, we know it's a problem. We want to make sure that we get oxygen on board if they have any kind of respiratory drive that appears to be elevated over normal, and then listen to lung sounds. You should never withhold oxygen if it's appropriate to give it to them. Now, what I'm not saying is if you walk in and somebody says, I got stung by a bee, you don't slap 15 liters of oxygen on them like right out of the gate, right? That's not the goal, is to see and do. The goal isn't to just be a skills monkey. We want to make sure that we're doing the best treatment clinically for that patient. And so we want to make sure that we're listening to lung sounds. If they have some kind of audible stridor by auscultation, we're going to give them the appropriate drug for that, which in some cases is going to be simply a duo-neb of albuterol and ipratropium, or in the case of somebody who is now perhaps compounding into 2 organ systems, epi will be the appropriate drug of choice. Moving further into that primary assessment, we're looking at circulation, right? And this is, we're touching our patient. We want to know what their skin condition is like, and do they have peripheral pulses where we've got a good radial, and if not, obviously we're going to move to the brachial and then the carotid, determining kind of where we're at. Now, histamines cause this angioedema, which is airway swelling, right? This is around the face, the mouth, the tongue, the throat, and we want to make sure that we're not there, and if we are, that patient is absolutely the candidate for epi at that point. The presence of shock indicates that that person is in a severe allergic reaction, aka anaphylaxis. Now, it should be a no-brainer that any unresponsive patient without a pulse should get basic life support, and that means CPR. Early hands on chest is absolutely where we need to go. It just so happens that that particular patient, because they are in cardiac arrest, are going to get epinephrine directly into the bloodstream, which with all hope, the CPR and the early epi is going to get the cardiac system back online, and the epi is going to help us mediate the anaphylactic shock. Anytime that we're dealing with somebody who has a significant, like we're talking anything over a moderate response to an offending agent, say a bee sting or some kind of ingested substance that causes an allergic reaction that's larger than mild discomfort, we want to make sure that that patient is transported immediately. More often than not, your patient is going to require definitive care to monitor and continue giving different drugs to kind of mediate this until the body is able to deal with the offending agent and remove it. History taking is really important in this particular patient because we really want to know, do they have a known allergy to a substance? It's going to help us identify what the problem is and how long this is going to take. If a patient is, say, allergic to a particular drug or a particular food and they didn't know and they ingested it and it's absorbed into the bloodstream before they could vomit or have some kind of significant bowel movement to help remove this agent, this could take several hours to completely remove it from the body, and now it's everywhere. If it's a localized particular situation, This may be dealt with a little bit more quickly, just based on the treatments given in the definitive care. And then we also want to make sure that we identify pertinent negatives so that we can rule things out of this. Again, sample history is king for this when we're talking about allergies, and this is allergies to everything, not just medications, but also environmental. So make sure that when you guys get into the habit of this, you can ask in your allergy section of sample, do you have any medication allergies? Because we should be doing that before we ever give any kind of drug. And then also ask about any kind of outside or environmental allergy, because sometimes these two things will go hand in hand. And in the case of this, I'll give you guys an example. This is, do you have an allergy to iodine, which is also going to be determined if they have an allergy to shellfish. The two go hand in hand. If you have an allergy to one, you almost always have the allergy to the other. And so you can see that this is going to play forward for you in the future. Anytime we're dealing with a patient with an allergic reaction, we're going to do that rapid primary assessment. And this is sick or not sick. And then we're going to do the backup of this, which is, does this patient have altered mentation? Do they have a increased respiratory drive? And how does their cardiovascular system seem to be dealing with this? You're going to give them 100% oxygen via some device based on what their respiratory drive is. And if need be, you're going to assist ventilation. You want to get that patient into an upright position and then make sure that you're considering that they may have an airway occlusion. Call for ALS if you think that they're going to have some kind of significant airway problem. You should probably always ask your patient if they know that they have anaphylaxis, if they've been intubated or anything like that, and then always try to remove the allergen. And so while we're speaking of this, this is try to remember that you need to remove any stingers that may still be in the skin. And that does not mean that you're sticking your fingers in their throat trying to get them to vomit. Right? That's not the goal there, but sometimes we have to say that. We're always going to treat with BLS. That's the start of anything, whether that be basics, AEMTs, or paramedics. BLS is really the core of the life support measures. So we're going to provide them with rapid transport to a hospital. The definitive care is where they need to be. We're going to give them oxygen as appropriate, treat for shock if they need it, which is gain IV access, and give them fluid boluses as needed. Or we're going to try to make them maintain their body heat, which is going to cover them up. We're going to treat for shock again, because now that they're vasodilated, they're radiating body heat, and we don't want the core body temperature to drop. If appropriate, put ice over the injury. If you're carrying ice and you can put it over the injury to kind of reduce some inflammation and swelling and provide some kind of pain relief, that would be great. In the EMT or the AEMT scope of practice, epi and diphenhydramine both are in the scope of practice. Now remember, diphenhydramine has a slow onset of action. It's not going to fix your problems immediately. This is something that's 20, 30, 40 minutes out. If your patient needs a medication right now, the first line drugs need to be albuterol and ipratropium for airway, and epi. Epi being the more specific one, because epi is going to work on two body systems. We're going to get that non-beta specific response, which is going to vasoconstrict and bronchodilate. So we're attacking the problem from both sides, whereas the albuterol and ipratropium are going to work on the beta 2 system, and that's going to cause bronchodilation. There's a little bleed over into cardiac output, but not significantly. It's not really going to cause a whole lot of vasoconstriction, and so it's not going to help us with hypotension and perfusion. In this picture, you can see using a credit card or an ID or some kind of plastic scraper to remove a bee stinger. We want to make sure that we're using something that's not tweezers, because what we don't want to do is actually squeeze the base of that particular venom pouch, because we will then inject more venom into them. So make sure that you remove it, wash them off with soap and water, and then you want to get the injection site below the level of the heart, which is just basically put them in a position of comfort and apply cold to the area to try to vasoconstrict right around that area. always be watching for these signs and symptoms of allergic reaction to move into anaphylaxis. And so you should note that if that particular patient has a, say, quarter-size wheal around the injection site from the sting, if it is expanding or you see hives moving up the arm towards the torso, or any of the other symptoms that we've previously mentioned, right? That's the increased respiratory drive that's not directly attributed to anxiety. If they start to have wheezes, or you see that their blood pressure is starting to drop, these are all signs that we're moving into anaphylaxis and we need to treat aggressively. Now, in the case of administering epi, the studies show that lay people are much more willing to give epi than the licensed provider. And we should really kind of move away from that. If these patients are epi candidates, we should never withhold that drug for them. The indication is a severe allergic reaction. So again, if they just have a small amount of swelling around the sting or whatever it is, right, that doesn't mean that we're going to give them some IM epi. That's not an appropriate reaction to what's happened. The patient should have at least a couple of signs and symptoms that this is progressing into an all-out anaphylactic response. And then in regards to contraindications, you're never going to give a person somebody else's EpiPen or an expired EpiPen. You're going to use your drug that came off of your rig. I'm not going to dive deep back into the actions on epi. You guys should know that from when we were going through pharmacology on epi. Do know that there are side effects associated with epi, which is an increased pulse rate. The blood pressure will come up. They may have some anxiety, and then in the case of older patients or even some younger patients that perhaps have some cardiac issues, you may see an arrhythmia. Last but not least, just remember that if you gave a single dose of epi, you may need to give another dose. Look at your local protocols, understand how many doses of epi you can give before you have to call for an MSEP. Try to make sure you're onboarding the rest of your drug algorithm in our local protocol. That would be epi, albuterol, ipratropium, diphenhydramine, and a corticosteroid. And our particular one seems to use dexamethasone. Hospitals will probably be using things like solumedrol. And try to make sure that you understand that as you're giving these particular drugs, that they have certain amounts of time before you're going to see the results of that drug. So again, if we're looking at epi, that should be an immediate response. You should see things changing within a minute to 2 minutes. If you're going to give diphenhydramine, you're probably not going to see any change whatsoever within the first 10 to 15 minutes. More often than not, it's going to be 20 and 30 minutes before diphenhydramine is mediating the histamine response that the body has. Anything like the corticosteroids can be anywhere from 30 to 60 minutes. That is not going to be observable in your normal short transport to definitive care. Now, if you have a long-term transport or like 2-3 hour transport to the appropriate facility and you're treating this patient, that's absolutely something that you should see the effects of pretty quickly. But the take-home point here is to understand that if we are in an acute situation, that epi is going to be the primary drug in the case of anaphylaxis. Never withhold that drug because you have some kind of fear about what it may cause. Withholding it is going to cause more harm than giving it 9 times out of 10. So as with everything else, if you have any questions, let's discuss this in class. This tends to be a pretty good subject for us to have lots of debate and discourse on. There is always something for everybody to learn in regards to anaphylaxis because no two cases are going to come out exactly like the textbook. And a lot of your instructors in lab or in other classes will tell you the things that they have seen and the things that they have missed when they were waiting for an anaphylactic response to come or were not expecting one to show up.